So I'm gonna make a short video about delayed sequence intubation or delayed sequence induction. It does seem as some people have gotten misinterpretation of a delayed sequence induction or delayed sequence intubation versus a rapid sequence intubation. So most of our patients, if not all of the patients in ICU, is a delayed sequence induction. Patients that receive anesthesia, basically all of them is a delayed sequence induction. So this is when we've got an hypoxic patient or patient that requires intubation but still needs optimization. So that's optimization with giving the patient oxygen. So the patient doesn't have enough oxygen reserve, so we still need to put this patient on either a high flow nasal cannula with a mask, or give this patient a non-invasive ventilation, or some sort of other type of higher level of oxygenation. We also need to optimize the hemodynamics of the patient. So we want to start the patient on, let's say, a noradrenaline infusion, or give the patient some fluid boluses before intubating the patient. So the function of the delay is to optimize the patient's hemodynamics. So that is giving the patient the proper cardiac output and making sure that the patient is properly oxygenated prior to the intubation. All intubations requires 3 types of medication or 3 types of drugs, and this is very important. We need to give the patient something for pain, we need to give something for sedation or anxiety, and then we can give the patient a paralytic, something to paralyze the patient with. When we give drugs, we should give drugs that we know. So we should give drugs that we are actually well known with, that we know what to expect. So a lot of people have got a lot of medication available to them, but they do not know what to expect when you give the medication. And I think that is one of the things that makes people scared of giving medication to patients, because they do not expect, or they do not know what to expect when giving a patient a specific medication. But with delayed sequence intubation and with rapid sequence intubation, we need to optimize the patient, and then start by giving the patient something for pain. It is painful to be ventilated, and it is painful to be intubated. So start by giving something for pain. When you start giving something for pain, you also ask whoever is with you to start preparing the infusion of whatever you give the patient for pain. Most pain medications doesn't last for longer than about 15 minutes to about 20 minutes. Some only last 7 minutes, so you need to follow up with an infusion. So a very common medication for pain for pre-intubation is to give the patient either ketamine, which is great, or give the patient fentanyl as a pain medication. Now you also need to know how long does that medication normally take to take effect. So let's say that medication takes about 1 minute to take effect, then you know when to give your next drug, the sedation. So then you can give whatever you want to use for sedation. So most people prefer propofol for sedation. It does suppress the intubation response. It is a fairly safe drug if you have prepared well, but there is also etomidate, there is dormicum, but I think one of the drugs that for me is a drug that is fairly predictable is propofol, and you can also give the induction dose of ketamine. Then after the patient, then also you need to know how long that drug is going to take to have its effect. And then after that you will give your paralytic drug. So if it is rocuronium, which I prefer, then you would give the patient rocuronium. If you intubate patients with succinylcholine, you then give your succinylcholine. The most important part here is to make sure that you know what is your timelines, so that the moment you give your paralytic, you are ready to intubate the patient with your plan A as soon as that paralytic is working. The idea of an RSI or a DSI is not to bag the patient prior to ventilation or prior to intubation. So you should not be giving these drugs put in an oropharyngeal airway and then start actually bagging the patient. You should by now have a patient with a high saturation, good hemodynamic parameters, and a video laryngoscope in the one hand and your ET tube in the other hand, intubating the patient and then immediately ventilating the patient. Remember, when you intubate the patient, you take away their PEEP, so you must add a patient's physiological PEEP back to them. So patient's physiological PEEP, which is somewhere between 4 and 5, you need to give back to them in the form of either a PEEP valve or by setting it on the ventilator. By this time, all your drugs that you have given the patient must also be available as an infusion, because these drugs are going to wear off. The worst thing that you can do is have a paralyzed patient, and normally your paralytic is the one that works for the longest. So you've got a paralyzed patient and the paralyzed patient is awake. So you've got an awake patient inside the body. This patient is not sedated and is feeling all the pain. So once you have given the drug, you can immediately start the infusion of that medication. So if you decided on fentanyl or morphine or whatever you want to give for pain, after you've given the stat dose, start the infusion. Same with the sedation. And then if you need to paralyze the patient post-intubation, and you do not want to keep this patient just sedated, you need to paralyze this patient, you need to follow up with a paralytic agent that's on an infusion basis. So during this, BP must be monitored, ECG must be monitored, SpO2 and CO2 must be monitored. Of all of this, CO2 is probably the one that will give you the most information. It will tell you about the patient's perfusion, about the patient's cardiac output, and even if you have placed the ET tube in the right place. Remember, primary confirmation is seeing the ET tube pass the vocal cords, and then secondary confirmation is listening with a stethoscope or using your ET CO2, and that should sort of be our gold standard of intubating a patient. A patient should never at the end of the day say that they have been aware of the intubation. And unfortunately, we see this many times where patients, after intubation, or I get their patients have been intubated, the baseline pulse rate was 80 and the patient has got a pulse rate of 130 and is being paralyzed. The reason for that patient's heart rate of 130 and high blood pressure is because the patient is awake, the patient is not sleeping, and the patient is not receiving pain medication. So you have to give those three things during and after a DSI. I will speak to you again very soon.